So good morning, everybody. Adherence to treatment is something that bothered me for a long time. And I have to tell you how that all started. Since it's not the first time I'm presenting something about adherence in the EGPRN, maybe you've already heard this story, but still. I was sitting in front of one of my patients, an old lady who couldn't speak Hebrew. And she came to renew her medications. And she was coming with her two of her sons. They were sitting in front of me, and I was looking at my computer, and I've seen that she haven't been visiting for a very long time, and she didn't get any prescriptions. And I was starting, to say what a family physician should say. This is really bad. I was very proud of myself. She was a diabetic patient. She got metformin, ACE inhibitor, statin, and aspirin. I mean, by the book, anything I should give her. And so I started to say, this is not good, and your mother didn't take your medication. This is, you should do something about it. And they was sitting in front of me and telling me, mom takes medication all the time. She takes them regularly. And in a certain point, I've realized that they're not lying. They're not saying anything to please me or to say, because this is the simple truth. I looked again at the computer, and it was 4 months from her last visit. She got 4 medications. She got 4 packages. Each one of them got 30 tablets. And after 4 months, they ended up, and she came to get new ones. So ever since, this whole issue of adherence to treatment is really something that bothered me a lot, and I'm thinking a lot about it. So this is the third study that we're doing about adherence to medication for chronic users. And we're talking about, of course, oral anticoagulants, and this is Doron and Alex are my colleague for a long time. So we all know that oral anticoagulants are effective treatment and they reduce the risk for stroke in patients with atrial fibrillation. And the new oral anticoagulant, we call it NOC, DOC, whatever, has 30% reduction in stroke, and without increasing the risk of bleeding. And we also know that if you discontinue and you stop taking them, you lose the advantage. I mean, after 1 month of discontinuation of the medication, we lose the risk increase back to the increase of someone who doesn't take oral coagulants. So the aim was to explore adherence rate to oral anticoagulants among patients with atrial fibrillation, and to compare head-to-head different oral anticoagulants, different medication in long-term, in chronic users, in real-world setting, because we all know that in when you do studies, it's all different. This is a population-based cohort study. We took all patients over 30 years with the diagnosis had a diagnosis of atrial fibrillation before 2016, and actually we started to get treatment at least in 2016. And they will have to buy at least 1 package of any oral anticoagulant during 2016, 17, and 18. This was to ensure that we're taking patients with chronic use, that they didn't change their treatment, because since we're dealing with database, we have no information about anything that the doctors actually is doing. He might say, stop taking this medication now or whatsoever. So, but if you take it for 3 years in a row, we can assume that this is a chronic use and it haven't been changed. And we analyzed the prescriptions that were filled during 2017. So, and we were taking, since you can purchase for 3 months in altogether, you don't have to come every month. You can buy it in Israel for 3 months, the 3 packages. So we count packages, how many packages they actually bought. Complete adherence is of course 12, but in the literature it's common to an acceptable 80%. So we take 9, if you buy at least 9 packages during the 2017, that's considered as good medication adherence. We overall had over 26,000 patients. And you can see that so we're using apixaban, warfarin, rivaroxaban, and dabigatran. This is the oral anticoagulants that are actually used in Israel. And you can see the adherence rate. And you can see that the adherence rate is very high for the new oral anticoagulants. This is, I'll show you later, the adherence rate for other medications, and this is really extremely high adherence rates. And you can see that the warfarin was much lower rate. Now we need to remember that for warfarin, you have to adjust adjust that treatment all the time according to the INR. So what we did, we also took patients who did according to a TTR, time in therapeutic range, and we added those who were in most of the time in therapeutic range, over 70% of the time, and it was instead of 56, it was 67%. Still a huge difference between warfarin and then the other oral anticoagulant. And it is important to remember, Shlomo did a study about it, and only 1/3 of the patients were in Israel at that time were a TTR of over 60. So that's suitable to what we're seeing here. What also interesting is to see what happened to the LDL and glucose level of this patient. They were taking oral anticoagulants. This is unrelated by any chance not to the LDL cholesterol or to the glucose level. And don't look at the numbers, there's small numbers, but you can see that there were the differences were very, very clear. And those who were taking regularly their medication and they have a higher adherence rate, have lower LDL level and lower glucose level. This is, as I said, this is the 3rd study we're doing. We did it for diabetic medication, also for hypertensive medication, and it always has the same profile. Patients who were adherent to the medication that we're testing, and they are not related to glucose or LDL level, were also having better results in these tests. We were looking for what might cause a better adherence, and the only thing that matters is age. Okay, as increasing age, you have a better adherence, and we all know that an older patient has better adherence than our younger ones. This is related probably to the time they have to absorb the idea they are chronic, they have chronic disease, they need to take care of it or whatever. And also this is the same, it was the same in the other studies. And we need to say that low socioeconomic status is not related to adherence. Well, we all think that, you know, what the patient pays is important. It is probably important, but not, if you're looking at in general, it's not, it doesn't work. And it's really important to say because the new oral anticoagulants are relatively expensive. They are more expensive than warfarin, for example. And still, it doesn't affect the patient either. Now, I just want to show you that this is something that that we should compare to what we have in earlier, and you can see that the adherence to oral anticoagulant is much higher than adherence, for example, that was measured in exactly the same way for hypertensive agents. And you can see the differences, and we should bear in mind that not all medications are equal. You know, there are medications that have better adherence rate and others that have a lower adherence rate. And I have to say that it was the same. I mean, we were talking about adherence to hypertensive medication, and still you will see they have lower LDL, they have lower glucose level, and then we are talking about hypertensive medication. What also we could see in this study that we couldn't do in oral anticoagulant, because in oral anticoagulant you get only one medication and you don't get any other medication from the same group. But what we did in medication in hypertension, for hypertension, we saw that if you were adherent to one medication for hypertension, you have much higher chances to be adherent to the other medications for hypertension. I couldn't show it here because it's not related to oral anticoagulant, but I guess this is one of the reasons that we saw the LDL and the glucose level that are higher. Now, we need to remember that the main limitation of this study is that this is a database study. We have no information about adverse reaction. We have no information about physician-patient relationship, nothing that is related to the daily interaction between patient and physician. And we don't know whether they were stopping the medication, to take medication because the doctor told them to stop, or it was their own decision. But still, we can get, I think, a better picture of what's going on around. So in conclusion, long-term adherence rate to the new oral anticoagulants among patients with atrial fibrillation is very high. And they have higher adherence rate than compared to warfarin. We need to take it to keep it in mind. And we should think about it when we choose oral anticoagulants. The new oral anticoagulants have lots of other advantages compared to warfarin. They're much easier to use and take, but still, we need to remember that they also have a much higher adherence rate. Thank you.